Honor guest, dear colleague, it's second year when we do the Congress of Black Sea Ophthalmological Society online from epidemiological circumstances, from epidemiological reasons. Of course, I prefer to have the real meeting, and I think many of us prefer the same, to have the real meeting. But the online connection offered the same maybe some advantages, to have the connection without to leave the home, to do something together, to do some event. And today we open the 90th Congress of Black Sea Ophthalmological Society, and I invite Professor Kaskaloglu from Turkey for some speech. Thank you.
Okay. Hello, everybody. Welcome to the 19th Congress of the Black Sea Ophthalmological Society. I will present you something about the society. Can you see my... Wait, I want to share my screen. Share screen, yes.
Yeah, I'll try and just
Yes.
Yeah, it's okay.
Can you see me and the presentation? Yes.
Yeah.
All right, just a moment. Yes. Okay. Well, again, welcome to the 19th Congress of the Black Sea Ophthalmological Society. I agree with Professor Bendelic. I prefer live congresses because I remember the excellent congress we have organized in Moldova in 2015, and we enjoyed the scientific program and also the company of our friends and colleagues. In future, maybe the next Congress will be live, but this is the best we can do. And I thank you very much, Professor Bendelic, for taking your time and organizing such a Congress, which I know is very difficult to do. But I wish you a very successful Congress. Our society is, as you know, called Black Sea Ophthalmological Society, and it consists of countries around the Black Sea: Georgia, Russia, Ukraine, Moldova, Romania, Bulgaria, and Turkey. And Armenia and Azerbaijan and Greece are associate members. The idea of the Ophthalmological Society is to form a society of ophthalmologists from the countries around the Black Sea. And our mission is to be a society of exchanging ideas and knowledge and experience, also friendship. Our vision is to be an internationally recognized society with regular meetings and exchange of students. And many of these goals are already realized, as you will see from the coming slides. The idea of Black Sea Society was realized during a meeting organized by one Boshandon company, actually, in Saint Tropez in the year 2000. And we sit down with Professor Diwali, and we originally decided to make a meeting together with Georgia and Turkey, but Professor Diwali said it's much better to make a larger society. So the idea of Black Sea Society was came to life in Saint Tropez. And this is the photo of the board in the National Center in Chisinau in 2015, which was an excellent meeting in an excellent Congress hall. And I can see that Professor Bendelic is very handsome from this photo. And this is the Congress Hall in 2015. It was the 13th Black Sea Ophthalmological Society. We have many memories from this meeting. And this is the photo of the first meeting of the Black Sea Society. This is in Tbilisi in 2002, where we sit down and officially signed a proclamation of the foundation of the Black Sea Society. And here, this is the original logo of the Black Sea Society. This is Professor Diwali, and this is me. We are much younger then. And during the Black Sea meeting in Tbilisi, we also had live surgery operations, several operations. So this is the history of the Black Sea. The first meeting was in 2002 in Tbilisi, followed by the second meeting in 2004 in Odessa, 2005 Istanbul, 2006 Anapa, 2007 Odessa, 2008 Varna, 2009 Batumi, again Anapa 2010, Istanbul 2011, and Sinaia, Romania 2012, Tbilisi 2013, Sochi 2014, Chisinau 2015, Odessa 2016, Sofia 2017, Cluj 2018, Istanbul 2019, and we had the Corona pandemic, and this time it was virtual meeting, in a very successful virtual meeting in organized by the team in Tbilisi, December 2020. Now we come to the 19th meeting in Moldova. Our society, as I told you, we wanted to become an internationally recognized society. So we are a member of the ICO, and we participated in several international congresses, like 2010 Berlin, 2012 Abu Dhabi, 2014 Tokyo, and we organized symposiums and several courses, and we are recognized also by the European Ophthalmological Society and the ESCRS Society. And we also had many more symposiums organized at several other national and international congresses. This is our meeting in Odessa 2004 in Professor Filatov's memorial room. And this is again in front of the Filatov statue in 2004. And the support of our colleagues in Odessa is very much, and we appreciate it very much. Also, we had very good social meetings. 2015, it was in Istanbul, and we had Professor Barsakyan, who is no longer with us. He's from Armenia. Unfortunately, we lost him. And this is the Black Sea meeting in Istanbul. And again, I will go, and this is in Russia, Anapa. The support of the Russian colleagues is very well appreciated. This is our meeting in Batumi, 2009. Now we come to the 19th Black Sea Ophthalmological Society Congress in Moldova. This time it will be a virtual meeting, and I hope it's going to be a very successful meeting, because I look at the program. It is a full program for 2 days, and today we have one session, but tomorrow and the next day it is a full day program. I wish a very successful Congress. I again congratulate Professor Benderic and his colleagues and the technical team for organizing this Congress, and I hope it goes without any technical difficulties, and it will be beneficial to all of us. And in the coming year, we will decide to do the Congress whether live or depending on the situation. Thank you very much again. Now I will ask Professor Vasileva if she is here, or Professor Diwali.
Dr. Kashkaroğlu.
Алло?
Yes.
Hi.
Hi.
Ужми това. Ужми програмата. Узина.
Yes, up here.
Hello.
Hello.
Everybody's here. You
Yes.
listen to me? Do you?
Yeah.
Yes.
Oh, so good. So good to see all of you.
You
and
are
to hear
welcome.
you. Oh, I'm welcome to my office, actually. Everybody, all of us are sitting in front of their screen, and I really hate this, but anyway, no other chance. So, unfortunately, because of quarantine, because of this epidemic, we can't meet in person. Virtual meetings have very little advantage, because it's easier to sit in front of your computer as to travel with all complications in dangers at present. My dear colleagues and friends, it's an honor, a real pleasure for me to address you at this forum today. I don't not to forget to congratulate the organizer, and special thanks to the dynamic leader of Moldova Ophthalmology and the president of this Congress, Professor Bendelic, our close friend for years, and who's also a founding member of our society. I think that it really was a great idea about 20 years ago to start this Black Sea Ophthalmological Society. You did a good job then, long ago. It looks like next year there will be a real celebration, hopefully in person. Okay, we are still in front of our screens now, but to try to fulfill the mission of our organization, as Mahmoud said, to share ideas, experience, and friendship. I'll repeat again that we hope next year, on occasion of 20th anniversary, to be together. Here I show you some pictures. This one is left, it is from Istanbul during the Tulips Week. It was wonderful congress and magnificent garden. Next to it is a picture from Odessa. I think it was in 1916. And on two pictures on the down row, I see three my good friends from right to left. You all know them. And also Marie-José, you can see her. It is a picture, but not of all, only of our founding board, but many people joined when they saw that we are going to make a picture, and a big crowd joined us. So there are a lot of Bulgarian and foreign guests in the court of the beautiful hotel of Marinella in Sofia. So it's very good that many people came with, not came, but it's difficult to change. Many people are supporting this event with many interesting, exciting presentations. I went through the program. It's really nice. We don't forget, we shouldn't forget our great mission to assure good vision for all and preserve the most precious human sense, sight. This goal brings us every year together, and in general in ophthalmology, our golden specialty. Unfortunately, it's evident we won't have amazing social program. We'll never forget how we were treated in Moldova. It was fantastic, even without like in a fairy tale, the time we spent under the ground, especially for those who got lost. Anyway, the eye, you all agree the eye is magical, and it's from antiquity, it is being idolized. The eye of Ra in ancient Egypt is a symbol of power and authority. Moreover, people believe that it's symbol of fire and light. And according to their ancient Egyptian beliefs, the eye of Ra was able to burn evil people. So I feel so good to see so many dear friends and almost to feel among you. Dear friends, colleagues, take care, stay away from COVID, and I'm looking forward to the very, very successful Congress. Thank you.
Thank you very much. Thank you very much. And well, yes, together and real meeting. Thank you. I like to invite Professor Dvali start to say something.
Yes. Thank you very much. Thank you, dear colleagues, dear friends. Thank you very much. Tell the truth, I miss you all, and I'm very glad to see you by TV, unfortunately, but anyway, everybody looks very nice. Take care of yourself. It gives me a great pleasure to extend to you all a very warm welcome to the 19th Congress of Black Sea Ophthalmological Society. I hope your families, your friends, and your colleagues are healthy and well. Uh, in 2002, when the BSOS was founded with the main mission to support, as my friend Mahmoud Kashkarovli said, the local ophthalmology societies, to support the local ophthalmology societies of 7 countries around the Black Sea. We could not imagine in that time that it will be possible not to see each other during the meetings one minimum once a year. But unfortunately, pandemic has taught us that the life with new rules, and we should live with the new rules, and that we should put health above all the other considerations. Despite challenges of the pandemic, ophthalmology has been progressing quickly, and we understand that we are responsible to enhance the educational and practical experiences of comprehensive ophthalmologists, young surgeons, and residents. I would like to express my gratitude to the Ophthalmological Society of Moldova and personally to Professor Bendelik for the organization of the 19th BSOS Annual Congress and enormous work that was being done during the progress. I think I think and I'm sure that this meeting will be as interesting, as successful and fruitful as all other previous meetings were. Cordial thanks to all of you for participating in this meeting and good luck to everybody. Thank you, dear friends. There is no microphone. Microphone switch off.
Yeah, excuse me. It's not real meeting. Yes.
Okay.
Well,
After 10
thank you.
years, I see we will be more friendly with microphone and screen.
Yeah. Thank you very much. Thank you very much. And let me invite the Professor Mircea Filip from Romania.
Is it okay?
Yeah.
Yes. 1 month ago, when I was invited to participate to this Black Sea Ophthalmological Society, I was very skeptical that could be done, but I was wrong. I'm pleased that I'm here. I was surprised so many papers are involved in this conference, and I consider that Zoom and other logistic systems help us very, very much to be together. This experience with Zoom and other systems was very difficult at the beginning. I say about our webinar, but now it's okay. You organize something very special. I think that could be done in small meetings, let's say, and point to some problem. And I consider that Black Sea Ophthalmological Society is a very good job for everybody. Thank you and good luck.
Thank you very much. And maybe this is other advantages of online Congress, when we can in very short time we can maybe do something together. Thank you. I invite Professor Nadezhda Bobrova from Ukraine.
No. Не надо. Давай, включай. Hello, everybody.
Hello. Yes.
Yes, I am very happy today to have so nice communication and take my great congratulations with the opening of the 90th BSOS Congress in Moldova. I do want to show you some photos because for since long period of time we are together in this very nice original ophthalmological community. And Ukraine was at the beginning of the BSOS Foundation, and now you see the second BSOS Congress in Odessa. Then, next one. Then you see the fifth BSOS Congress in Odessa in 2007, also in Ukraine, and in 0216. Also in Odessa, very nice, very important Congress, and great respect, I would like to say, to our Moldavian colleagues. And I would like to mention, of course, Professor Evgeny Bendelik, and also Professor Valery Kushnir, and Professor Jan Jerry, and I know many other persons who in this difficult time due to COVID pandemic decide to organize our Congress, 9th BSOS Congress. So I would like to say good luck, good health to all participants, to professors, to lecturers, to students, to doctors, and our patients, of course. So everyone, thank you for invitation, and I'm proud, and I hope to proceed my work in BSOS. Goodbye.
Thank you very much. Thank you very much. Thank you very much. And I invite Professor Alexander Zabolotny from Russia.
Hello, my colleagues, dear colleagues.
Yeah, hello.
We are going to have a very good weekend days. The communications with colleagues on our favorite business. Ophthalmology is a part of your life. I'm glad to see my colleagues and friends in full health. Interest in missing new knowledge, good life of organization. Thank you.
Thank you very much. Thank you very much. Well, thank you very much for all participants, and especially many thanks for boards of Black Sea Ophthalmological Society. Many thanks for my colleagues, for local organizing team, and many thanks, of course, for speakers, especially for speakers, and of course, the many thanks for sponsors. Well, and before we will start the first session, before we start this symposium, I like to ask you if it's possible to put the camera, and we try to take some pictures for the historical pages of Professor Kaskaloglu, and for all boards of Black Sea Ophthalmological Society. We try to open the camera, and I ask my colleague to try to do the picture.
Ne polozuję czego?
Okay, thank you very much. My staff, my colleague inform about the successful take the picture. Thank you very much. And how I say earlier, from epidemiological reason, we do this Congress online, and from the same reason, the first session of Congress we dedicate to the same topics. And I have the special pleasure to invite our friend for years, friend of Black Sea Ophthalmological Society, Professor János Nemec from Hungary. Welcome to 19th Congress of Black Sea Ophthalmological Society.
Hello. Hello. Thank you. Thank you, Professor Brendelic. First of all, I greet all my old friends and colleagues, and for the audience as well. And first of all, I would like to thank very much for the very kind invitation to Professor Brendelic, and for the very excellent organization of this meeting. It's a very great honor for me to be here and speak about the myopia and management of myopia, together with my colleague Beata Tapasztó from Budapest, from the same department. So our course is based on the content of the just published update and guidance on management of myopia. It was decided to write and publish this one by the European Society of Ophthalmology, and it is in cooperation with the International Myopia Institute. Here you see the list of the authors. And this publication appeared in March and open access, so you can read the whole article, a whole guideline free of charge using the European Journal of Ophthalmology homepage. So the myopia affects a lot of people worldwide. WHO said that 2.6 billion people lives around the world with myopia, and the myopia is still increasing, and expected that by the time of 2050, it will be around almost 5 billion people with myopia, and by that time the number of people with high myopia will almost reach 1 billion people. So it's very huge amount, and that's why the pathological myopia is predicted to become the most common cause of irreversible vision impairment and blindness worldwide and also in Europe in the future. Here you see the European data, and estimation also show an expected unfortunate increase in the near future. Unless we act now, and we have to act now, I think that is the main reason of this guideline, because we have effective interventions. And in the second part of this course, we will speak about that interventions. So the main aim of this course to increase awareness and to provide recommendations for eye care specialists, how to prevent myopia onset and how to reduce progression of myopia. This course will consist of 2 lectures. I will speak about the definition, genetics, epidemiology, and risk factors. And in the second part, Beata Tapasto will speak about the management possibilities and the guidelines. And at the very end will be questions and answers. So about the definition of the myopia, it's very well known. So it's a refractive error in which rays of light entering the eye parallel to the optic axis are brought to a focus in front of the retina. And we also know that there are 2 reasons for being myopic: a too long eyeball or a different refractive power. That's why we classify axial myopia with greater axial eye length and refractive ones, which changes in the location or structure or dioptric power of the cornea or the lens. And besides, there are secondary types as well. It's more important the quantitative classification because it's different in different articles. So we followed the International Myopia Institute definition, which is widespread accepted. We use the same definitions here in the guidelines and during this lecture. So myopia is defined as a spherical equivalent refractive error, equal or less than -half diopter. And low myopia is between -half and -6 diopters. And we are speaking about high myopia if the refractive error is more than 6 diopter in the minus range or equal to -6. And an important category is the premiopia in young children, which might include a risk or likelihood of future development of myopia. In young children, it is between the refractive error 0.75 in the plus diopters till minus half diopter. Here you see the pathogenesis slides, and we might say that myopia onset and progression is a result from a complex interplay of visual environmental conditions and genetic factors that modulate the eye growth. Retinal defocus initiates a signal cascade that leads to a number of cellular and biochemical changes in the retina and in the retinal pigment epithelium. These chemical signals are transmitted through the choroid. The choroid releases growth factors that have the potential to regulate scleral extracellular matrix remodeling and leading to increases in ocular growth and a more myopic refractive state. And the genetics, we have to say again that myopia is caused by a complex interplay between genetic and environmental factors. To date, more than 600 loci for refraction and myopia were identified. And persons at high genetic risk have an up to 40 times increased risk of myopia compared to those who have a low genetic risk. And we have to know about the secondary syndromic forms of myopia, Marfan syndrome, Stickler syndrome, and Donnay-Barrow syndrome. And an ophthalmologist need a more deep examination if the myopia onset is in a very young age. And you might think about this syndromatic forms as well. So concerning the epidemiology, we expecting by 2050 in the world population, half will be myopic and about 10% will be high myope. So it includes a huge medical and financial importance. Here you see the estimated increase in myopia prevalence in East Asia. Nowadays is above 50%, but will reach more than 65%. And here you see the European trend lines, estimated trend lines. And these are lower than in East Asia, but still they are very high. Here the East European data nowadays is not 18%, it was 20 years ago, but 32, and we'll expect to more than 50% in the next 30 years. So it's a huge increase and huge change, unless we act now. And that's why I stress this, that we have to act now in many ways. And about the different age groups and the prevalence of myopia, we might say that an early age onset of myopia appears to be the strongest predictor of high myopia. The highest rate of onset of myopia is currently observed in children aged 7 to 10 years. Here you see in this graph, which shows the European trends in different ages of children, the prevalences of myopia, and in Europe and in Asia, that around the age of 6 to 6 is there is no myopia, and then starts the myopia and increases a lot till the age of 20. In East Asia, it's around 90%. They expect that is the true values published in the last 2 decades from Europe and Asia. And what about the stabilization of myopia? By the age of 15 years, almost half of the myopic children stabilize. And the evidence shows that myopia have to stabilize in most myopic individuals by the age of 24 years, except high myopes. Here you see some Hungarian data about a huge population of Hungary from young to till the very old. And we found a few years ago that the myopia prevalence or relative distribution is more than 40% in the population. So it's higher than it was earlier here in Hungary. And here you see the mean refractive error in the different age groups. In young, the average refractive error is in the minus range, and in the middle ages, it's close to emmetropia. Then the population is hypermetropic, and then again myopic. And here you see the relative distribution of the frequency of refractive errors in different age groups in Hungary. And we might say that there are around 3 times more low myopes in the younger generation born after 1970 than in the earlier generations, and more hyperopes in the older generation born before 1960, also due to the hyperopic shift during the aging process. And finally, above the age of 76, again, more low myopes due to the nuclear sclerosis and also as a result of the lens implantation. So concerning the risk factors, there are 3 main categories, and the personal characteristics, the binocularity, and environmental factors. So we already touched that point that there are major differences in different continents and ethnicity. Concerning the gender, we and the publication showed that in females, the progression of myopia is faster than in males, and there are more myopic person among females. And parental myopia, more parents with the history of myopia is connected to the higher prevalence of myopia among these children, and especially the amount of myopia in the family is a connected factor of an increased risk of being myopic. And this one is not based only on genetic background, this parental myopia, because there is a shared lifestyle transmitted by education from parents to the children, which might be a significant factor besides the genetic background. So the personal characteristics, the cognitive functions are important, and higher the verbal and non-verbal EQ, the higher the risk of myopia. So, and education at all triggers the onset of myopia, and the higher academic degrees is associated to more myopia. So in many publications wrote about that there is a causal role in the development of myopia by the education and level of education. But it's again a question whether it's an independent variable or not. Due to that, we know that education mainly goes inside, which means less time outdoors, which is a very significant risk factor alone as well. So it's a so-called combination. Physical attributes, there are many publications with how to correlate with body height and body mass index. And birth circumstances are important. It's very clear that low birth weight is a significant risk factor to have myopia. We might think about the mild degree of retinopathy of prematurity at the later stages. And or which months in the year might connect it to more myopia. Summer and autumn months are connected to more myopic children than the winter time months. And binocularity is an important factor. Myopia onset and progression were found to be related to an elevated accommodation convergence per accommodation AC per A ratio, which could be observed before the onset of myopia. And it's important that you can observe before the onset of myopia. And deficient accommodation, accommodative response, so-called accommodative lag, and consequential hyperopic retinal blur during near viewing activities may be a stimulation to axial growth of the eyeball. So an increased AC per A ratio was a predictor of myopia onset and was associated with a greater accommodative lag in the publication. And we might say that abnormal binocularity might be a risk factor for myopia progression. So, and the most influential risk factor is the environmental ones. And more time spent indoor increases very much the possibility and the chance or risk to be myopic in contrast with the outdoors, which is a preventive effect on the onset. And we don't know exactly that the brightness of light or UV content of the light or other factors might be in the center of the pathogenetic mechanism, but there are some evidences that high bright light indoors might prevent the childhood myopia in school year children in East Asia. And more near work increasing and is a real important factor, and it is connected to the increasing educations all over the world. And in that case, the defocus signal on the retina plus the accommodation like both lead to the more elongation, axial elongation of the eyeball. As a very interesting question is the black text on white paper in contrast with white text on black paper. And the experts say that white text on black paper, just reading such condition, thickening the choroid, and the sickness and the thick choroid is a preventive factor against myopia. So that might be a consideration for the future. Black text or white text on black paper or black monitor screen. And almost finally, the use of computers and smartphones is a very well known. And during this pandemic, as Professor Petya Vasilyeva already mentioned, is a very important plus risk factor for more computer use and smartphones. And this one is also connected to the indoor lifestyles as well, and not with the outdoors. That's with a complex thing. And there are other factors which were examined in the past and in the recent years, and like the location, rural versus urban living or socio-economic status. So finishing this, based on this risk factors, the interventions for controlling myopia, the public health lifestyle interventions, and optimization of environmental influences seems to be very important. So now I will invite Beata Tapasto to speak about the controlling and the guidelines. Thank you very much for your kind attention. Yeah, inviting Beata Tapasztó to speak, to share the screen.
Good afternoon, dear colleagues. I am waiting to share my screen, but it's not allowed yet. Okay. So to continue the presentation, I would like to talk about the management possibilities and the guidelines of myopia. The course is based on the European Protocol of myopia, which was published in this spring, and we have heard about it. The prevalence of myopia, as we heard in previous presentation, indicates the importance of myopia control interventions. There are several methods for controlling myopia. Environmental considerations, there are optical devices such as special design spectacles, special design contact lenses, or autokeratology. There are pharmacological agents from which atropine is the most important. There are surgical interventions, and there are combination therapies of these. Let's talk about at first environmental influences. Increasing outdoor time or indoor time level has significant effect on myopia onset and progression. Every additional 1 hour outdoor time per week leads to a reduction in risk of myopia by 2%. Optical devices may play an important role in myopia control. Spectacles are easy to use. These are well tolerated and non-invasive, but undercorrection is not beneficial and can be harmful. There are studies about bifocal spectacles or progressive additional lenses which has small effect in slowing myopia progression. But novel spectacles lens design, such as peripheral defocus correcting lenses, this is something new. This type of lens by Zeiss was reported inconsistent results, and there was no difference in axial length change compared to a conventional single vision eyeglasses in a 1-year trial. But here is another new thing, a novel spectacle lens designed by Hoya with DIMS technology and with myopic defocus of 3.5 diopter, which has promising results not only in refraction, but axial length as well. After spectacles, there is evidence to use specific myopia control soft lens design and autokeratology, which have similar effects. The mechanism is to induce myopic defocus on peripheral retina. Now I would like to look at autokeratology a little bit more details. There is an average 50% reduction in the rate of axial length, but efficacy may decrease over time, and there is a rebound after discontinuation less than 14 years. Of course, there can be complications of contact lens wear, such as overnight use is associated with a higher risk of microbial keratitis than use during the day. But evidence suggests that autokeratology is a safe option for myopia retardation, and the risk of severe keratitis is similar to other overnight modalities. Atropine has been proved that the most important effect can reach, but it's not through the accommodation. It's interesting because atropine stimulated the extracellular matrix biosynthesis, thickening the scleral tissue and reducing the tendency to elongation. Besides atropine, there are other methods which we can use, but it's not suggest them for myopia control because there is no evidence to suggest them. Even I might mention this 7-methylxanthine, which is used in Denmark and taken orally twice a day in a tablet form. Let's look at this table. This is my favorite. It shows the concentration of atropine, and it shows the mydriasis, the side effects of the atropine. It's commonly believed that the low doses are more effective because the higher doses has a rebound effect after discontinuation. And the higher the dose, the higher the rebound effect. But from this table, low doses atropine has not enough effect in axial elongation, and the higher dose has unacceptable mydriasis. So the best position is somewhere in between. There are surgical interventions, but we all know that surgery is invasive in nature and should not be recommended as a first-line treatment modalities. And what are the recommendations for children based on the above? The most important to recognize pre-myopes, having myopic parents or family members, having a lifestyle with excessive near work or increased indoor time, plus 0.75 diopter or less hyperopia at the age of 6, or insufficient binocular vision, reduced accommodation flexibility, means a risk of myopia at an older age. So we have to observe these children more closely and to encourage them to spend more time outdoors as an evidence strategies. Monitoring axial length changes can be informative, not only in progression, but in identifying children at risk of myopia. There are charts which give information about the risk of developing myopia or even high myopia at later ages. So these charts can be different at boys and girls and can be different younger or older age groups. So we can use them to estimate the risk of later myopia. To select myopia control methods, the easiest way to give lifestyle advices to the children to influence the environmental circumstances. For near work activity, reading distance should be 20 or 25 centimeters or more. Continuous reading should be 45 minutes or less. If it's possible, children keep the head straight, no head tilt, no gaze down, no closer nip to fingertip distance, as you can see in the picture. Have to increase time spent outdoor. A minimum of 1 or 2 hours per day is essential if I count well. Have to maximize indoor light and have to use natural lighting and avoid LED lighting, which can cause axial elongation. Recommendations for spectacles. Children should be encouraged to wear their full myopic correction all the time because we would like to avoid undercorrection. Novel method spectacles with DIMS technology are preferred. And now let's focus on contact lenses. Orthokeratology, and this is a special design soft lenses beside orthokeratology, offer similar levels of axial length control. If it's not enough to use orthokeratology, we can customize this type of lens to bring more plus power inside the pupils and achieve a greater shift in relative peripheral myopia. Soft multifocal lenses are preferable for any patients who have less than 2 diopter of refractive error, and the photophilic pupil size is smaller than 4.5 millimeter. In atropine therapy, in children who worsen on low-dose atropine, we can increase the frequency of application or the dose. Use higher dose atropine is better than lower dose because we have seen that lower concentration allow an unacceptable level of axial length progression. Use of atropine therapy needs to be balanced against side effects. And after stopping treatment, it may be necessary to monitor children for further half or 1 year to ensure that there is no further rebound. And of course, there are combinations. Mostly we combine the optical devices with different doses of atropine, because due to dilated pupil, the myopic defocus effect of optical devices is more pronounced on the peripheral retina. And how long treatment should be continued? At what age is the probability of stabilizing myopia? We have heard previously. At a younger age, 7 to 12, there is a rapid progression, so we have to do something. At the age of 15, half of the children stabilized, and at the age of 21 or 24, almost completely stabilized the myopia. There are recommendations for the main two interventions of myopia control. For atropine, treatment effect with low-dose atropine should be maintained for up to 4.5 years. And for ortho-K, discontinuation of ortho-K lens wear before age 14 lead to a more rapid increase in axial length. There is a battle going on between those who believe in atropine and who believe in autokeratology. We are waiting to see who will win the war. And thank you for your attention. And now I would like to hand over the question and answer session. If there are any questions.
I have a question. Do you, maybe you have, or somebody of the participants have the experience about surgical methods, reinforcement, I mean, which was very popular, I think, from our colleagues from Bulgaria and Ukraine, and maybe in Moldova also. During the Soviet Union, it was very popular surgery, treatment, and scleral reinforcement. We call it scleroplasty. And there was different modifications. Do somebody have the experience with Snyder-Thompson surgical procedure, reinforcement? I think you know, because another is a so-called pivovarus method. It's a very easy surgery manipulation, but I think it's not so effective as Snyder-Thompson's one. This is my question to the audience, and maybe the Beata to you also.
Yes, yeah. It's mostly used in Central or East Europe. In Hungary, there is one place, not in our clinic, but there is one place when there are some very rare surgery of this posterior scleral reinforcement. Yes, but very strict how to choose a patients. For example, it's higher than 30. I have a patient, I sent her because she's an 8-year-old girl, and she had more than 30 millimeter axial length, and it's progressed.
How old she is? How old
she is 8 or 9 years old.
About 18?
Yeah, and there is a progression, and there was not a secondary myopia. In the family, yes, there is a myopic parent, but there is a huge elongation every year.
Nobody have experience with Snyder-Thompson's method, yes, as I see. Nobody. Mahmoud, no.
No.
Evgen, no? Because it was, I think it is a very good procedure, by the way, and you can read the articles about it. By the way, Avetiso also had some modification of this method, and we use it, and we think that it's have to stop myopia when it progresses axial progression when we have. Sure. Okay, thank you.
I have a question. Thank you very much for the nice presentations, very informative. I want to emphasize one point, because we see such patients quite often. Young children go to doctors, optometrists with myopia and astigmatism. They are giving glasses because they can see very good with glasses, but soon it increases and they go to another doctor, and by the time they come to us, they have keratoconus. I recommend that all the patients, young patients with myopia onset should be checked by topography in order to diagnose keratoconus early. This is a very important point, and it is not well practiced in many parts of the world. Also, because you have mentioned that myopia control with several other methods with pharmacological or orthokeratological, several companies, especially Topcon and I think another Oculus, now have special topography and axial length measurement instruments together in order to follow up children with myopia, which can be incorporated in our practices. So we can check for axial length increase, and at the same time, the existence or not existence of keratoconus. This is my point.
Okay, thank you. Thank you very much, Mahmoud. Do you hear me? Yes, it shows that it's a very complex the disease and needs deep ophthalmological examinations or screening for other causes of myopia to treat adequately very well. So then I think we have our role in the prevention and management of myopic children, but there are some other, but we handle mainly the progression and try to reduce the progression of the myopia, which is not the initial event in this process. So it might be need a broader view and need to speak with the decision maker to change the lifestyle in the education and have the children more time outdoors and so on. So what did the government did in China, and they tried to reduce the onset of myopia during that they built classes with glass on the top to have sunshine inside the schoolroom and so on, and mandatory to have many time outdoors during the school time as well, and no homework for school children as well. So to reduce the near work and improve and increase the outdoor activity. So it's a little bit beyond our ophthalmological practice, but who might speak with the decision maker about that need? I think we might speak. Thank you.
Yeah, I have one more point, because most ophthalmologists have this question asked by parents very often. How all the children want to use the telephone and the iPad. I take my granddaughter to school every morning. Before saying good morning, she asks for my telephone. So how much should we let them use the telephone or iPad? The young children, 7 years old, 3 years old. Is there a guideline?
I would like to comment that in Netherlands, there is a law that children under or till age of 2 can't use these devices. And till the age of 5, they can use only 1 hour per day. It's a recommendation or a law, I can't remember, but it's a rule in Netherlands.
So it's need to distribute the information to the parents to know about that. What does it mean? And if you see the statistics, in students and young children every 2 seconds look at the smartphone, and so even more because during all the day just checking emails and so on. So it's far more than when there's a continuous work. We might to limit that one. So okay, it's a very important point. Need a governmental decision to increase the awareness of the parents and reduce somehow that one.
If there are no other questions, can we continue with the session? Bendelik, Professor Bendelik?
Yeah, I like only bring my many thanks for Professor Janusz Nemetz and for his team for this very interesting presentation. And of course, the myopia is instilled to be one of the biggest, one of the #1 problem in refractive errors. And I don't know, maybe in the future, this low myopia become to be like emetropia, not the pathological state, because many young people, of course, have some modification of refraction. Well, thank you again, and for this very interesting material, for interesting presentation, and thank you for you participation in a Congress of Black Sea Ophthalmological Society. Thank you very much.
Thank you.
And well, dear Professor Kaskaloglu, please, you can continue the program, and thank you.
And thank you very much. Now we start the session on COVID-19 and the eye. Professor Duvali and I will be the moderators. And I would like to ask Professor Duvali to introduce the first presentation.
Good afternoon. Good afternoon, dear colleagues. I'll be presenting this presentation and I will share our experience. First of all, I would like to thank each and everyone who participated in the process of Congress organization. I know how it's a huge work, and I would like to thank all the moderators and participants for finding time in your busy schedule to participate in this meeting. And today I would like to draw your attention to the consequences of the COVID-19 pandemic on our ophthalmology practice. When COVID-19 was first declared as public health emergency of international concern, no one could have imagined that it would go on for months or even for years, and it would have such a huge impact on our everyday life. Considering the close contact required during the ophthalmic examination and treatment procedures, it poses a serious challenge on the ophthalmologists because there is a high risk of infection transmission, and the infection control measures universally recommended have been divided in 3 different categories. The first one is that we should use personal protective equipment. The second one is environmental control, and the third one is the administrative control. At the beginning of the pandemic, when the whole country was put into the lockdown, our outpatient clinic was temporarily shut down, and this was a time when my colleagues decided that telemedicine was a promising tool to interact with their patients. people, we are using various social network platforms such as Facebook, and you can see on the desktop that these are the groups that we are created at that period, MedRoom, MedGuide, and these groups allowed our citizens of our country to interact not only with the ophthalmologists but with the doctors of all the specialties. And all these groups include members of more than 50,000. The photos presented on this slide are sent to our doctors by their patients. And we all understand that the modern society is very open to electronic encounters, and they find it easy to communicate via means of video and telephone conferencing. And although there might be some challenges for older generation, but they usually find their children, grandchildren, relatives, or neighbors who can help them to communicate with their doctors. And all the patients who we are contacting my colleagues, they will receiving advice, in some cases treatment, and some type of recommendations. So they and no one was left without attention. Soon after the lockdown measures were lifted, we realized that we should live with this novel planning, was that we should adapt our practice so that we have to maintain balance between saving the vision and improving safety measures. The first point was to provide our staff with personal protective equipment. These were surgical masks, gloves, gowns, eye protection, which can be used for this purpose. Goggles or face shields can be used, and patients where all the patients are asked to refrain from speaking as much as possible during slit lamp examination. And as we know, there are reports that suggest that COVID-19 could be transmitted by aerosol contact with conjunctiva, and hence protecting ocular surface is crucially important. But in our country, wearing a face mask is mandatory and is regulated by the national legislation. But we think that there is no proper attention paid to the protection of ocular surface. We all do remember the faces of our colleagues, especially frontline health workers, and we remember scars on their faces from wearing the goggles, face shields. And for this reason, I would like to share our concept, which was suggested by Professor Douali. And we think that implanting temporary punctal plug in upper and lower lacrimal puncta can prevent SARS-CoV-2 transmission from the eye to the respiratory system. And Professor Douali will talk in detail tomorrow in his presentation about our concept. Regarding environmental control, we all remember that from at the beginning of the pandemic, there were no any type of specially manufactured shields for slit lamps, and we had to prepare these type of shields from any materials that was suitable for this purpose. And I remember that several of them we have prepared even from old X-ray films. But now this is the first photo shows the one shield which we had at the beginning of the pandemic, and the second one is specially manufactured for the slit lamp. All the slit lamps in our clinic are equipped with this type of shield. Also, it's vitally important to this reason special solutions are used. And special attention is paid to the air ventilation, and it's better if we achieve high rate of fresh air with improved air dilution. As we know, maintaining social distance along with the wearing masks, these are the two most important factors and most effective factors that prevent the spread of COVID-19. And in the clinical setting, so maintaining social distance can be achieved by blocking the alternating seats, and this helps us to prevent crowding in the waiting areas. But because of mandatory need of social distancing and also frequent disinfection required for these spaces, we considered and lowered the schedule volume in comparison with the time before the pandemic. But here we faced another problem because there was increased demand for ophthalmic service, and we had to increase the working hours of our ophthalmologist. In addition to the above mentioned infection measures, we applied structured reorganization, which meant screening of the patient for COVID-19 and all the patients who were applying to our clinic or calling our call center, as they were encouraged to use the means of telemedicine by video examinations or remote telephone-based interviews in order to reduce their visit to the clinics. Our ophthalmologists, nurses were divided into teams to reduce to prevent cases of infected coronavirus staff members, and we decided to place imaging devices in 2 different rooms, and as it is regulated by the government legislation, all the staff members undergo planned PCR testing every 2 weeks. Talking about specific measures, we all know that cataract surgery is considered elective surgery, and during the pandemic, we had to cancel elective surgeries. But as the American Academy of Ophthalmology has recommended, in some cases, cataract surgeries can be considered as semi-urgent. These are, for example, cases of cataracts which are interfering with the ability of patients to drive, work, or see their medication which they are receiving for their health condition, cataracts which cause increasing risk of falling down, and also annoying anisometropia. Some surgeons have suggested that it's better to perform sequential bilateral cataract surgery to decrease the risk of infection exposure, but we have not implemented yet this in our practice. All the patients planning to undergo any type of surgical intervention, it could be a cataract surgery, vitreoretinal intervention, LASIK procedure, or any type of refractive surgery, are undergoing a rapid COVID-19 rapid antigen test, and only in cases if the test is negative, they are scheduled for the surgery. And also in the OR, it's highly only single-use instruments are used, and I would like to use here the quotation from Professor Zauder's article that it's better to throw it by the end of the surgery, to throw everything away except the patient and the surgeon. And we also actively participate in a social campaign which promotes vaccination in our country, and our doctors are holding papers which describes that we get vaccinated to protect ourselves, our colleagues, our patients, and our family from COVID-19. And I would like to proudly announce that our clinic was considered the COVID-safe clinic because 100% of our staff is COVID vaccinated. And of course, we shouldn't forget that 2 most effective measures against infection controls. These are wearing masks and keeping social distance. controls. Thank you for your attention.
Okay, thank you very much for this very good, interesting presentation. We will have question and answer session after the whole meeting.
Okay, thank you very much, Professor Kashkalalov.
Thank you. Now
Thank
the second presentation is by Professor Asker Bulut from Istanbul. The effect of COVID-19 home confinement on myopia progression in children.
Good afternoon, colleagues, dear colleagues. My name is Asker Bulut. I am working as an assistant professor ophthalmologist at Istanbul Medical University. I respectfully greet you all before starting the presentation. First of all, I would like to thank Black Sea Ophthalmological Society management for giving me this opportunity to my presentation. I hope our next meeting will be face-to-face rather than virtual. The title of our study is the effect of COVID-19 home confinement on myopia progression in children. There is no financial interest in this study. The aim of this study is to investigate the effect of COVID-19 home confinement on the increase of myopia in the pediatric age group. For this purpose, the files of myopic patients under 18 years of age who were examined in the outpatient clinic in the last years were analyzed retrospectively. Subjective reflection values determined from the patient files in 2018, 2019, 2020, and 2021 examination between March and May were examined. Myopic progression over the years was analyzed by calculating the manifest reflection spherical equivalent value. Exclusion criteria were severe ocular disease, cylindrical refractive error of 1 diopter or more, degenerative myopia, ocular surgery history, ocular trauma history, and collagen disease. The mean age of 210 patients was 50.08 plus minus 2.02 years. Of the patients, 217 were female and 92 were male. The main manifest reflection spherical equivalent values 2018 minus 1.83 plus minus 1.19 dioptry. 2019 minus 2.14 plus minus 1.26. 2020 minus 2.46 plus minus 1.46. 2021 minus 3.20 plus minus 1.36. Each period there was a significant increase in myopia compared to previous one. This table shows the progression of myopia over the years in our study. When we look at the literature, we see that there are many studies related to progression of myopia. In this study, a substantial myopic shift was found in the 2020 school-based photo screening compared with previous years, 2015 to 2019, for younger children aged 6 to 8 years. The prevalence of myopia in the 2002 20 photo screening was higher than the highest prevalence of myopia within 2015 to 2019 for children aged 6 to 8 years. The differences in spherical equivalent refraction and the prevalence of myopia between 2020 and previous years were minimal in children aged 9 to 13 years. Home confinement during the COVID-19 pandemic appeared to be associated with a significant myopic shift for children aged 6 to 7 years, according to 2020 school-based photo screening. Younger children's refractive studies may be more sensitive to environmental change than older age, given the younger children are in a critical period for the development of myopia. This study shows us that among 6-year-old children in Ganja, China, the addition of 15 minutes of outdoor activity at school compared with usual activity resulted in a reduced in this rate of myopia over the next 3 years. The present study showed that myopia progression was associated with time spent on reading and writing and initial refraction value during puberty. However, myopia progression was not associated with parental myopia, age, gender, and daily time spent on using computer, watching TV, and outdoor activity. Although myopia in childhood seems progressive at all times, it has progressed more significantly during the COVID-19 home confinement, possibly with the effect of spending more time in closed environment and increasing indoor activity. Thank you for your attention.
Okay, thank you very much. And now we have Dr. Atılım Demirtaş and Berna Yüce. They are going to present visual field artifacts in glaucoma with surgical face mask used during the COVID-19 pandemic. Atılım.
Good afternoon, dear moderators and my colleagues. Today I want to share our paper named Visual Field Artifacts in Glaucoma with Surgical Face Mask Use during the COVID-19 Pandemic. The coronavirus disease 2019 pandemic has caused difficulties in the diagnosis and follow-up of glaucoma. In addition, fogging artifacts have been defined in the visual field test due to the mandatory use of face masks. In this study, we aim to demonstrate that visual field test reliability indices improve when face masks are taped in order to prevent fogging artifacts. For patients with glaucoma suspect, ocular hypertension, or glaucoma underwent visual field test with the 24-2 CITAFES test of the Humphrey Field Analyzer while wearing surgical face masks with their own near glasses. Abnormal visual field test reliability indices and pattern deviation plot comments are summarized in the next slides. Case number 1. 58-year-old female with bilateral glaucoma suspect. Fixation loss was high in both eyes. False positive error was high in the right eye. The glaucoma hemifield test was outside normal limits in the right eye. In pattern deviation plots, central artifact was observed in both eyes. Case number 2. 47-year-old female with bilateral primary angle closure. Fixation loss was high in both eyes. False positive error was high in the left eye. The glaucoma hemifield test was outside normal limits in both eyes. In pattern deviation plots, upper peripheral artifact in the right eye and central artifact in the left eye was observed. Case number 3, 46-year-old male with bilateral ocular hypertension. Fixation loss was high in the right eye.
The slides, because I see the same slides.
Now, can you see this slide, case number 3?
No, I see the first slide. Can you make the present, or just click on the fourth slide?
Okay.
Now, okay. We just go on like this, okay. Because we didn't see the other slide.
This slide, can you see?
Yes, go on.
Okay. Then I'll continue from here. 4 patients with glaucoma suspect ocular hypertension or glaucoma underwent visual field test with the 24 to CITAFAS test of the Humphrey field analyzer while wearing surgical face masks with their own near glasses. Can you see now the 5th slide?
Not yet.
I can see 4. Now you can click the 5th on the left.
Can you see these results slide?
You have to click the number 5 on the left.
Okay. Okay.
Okay. Yeah. Yes. Fine.
Abnormal visual field test reliability indices and pattern deviation plot comments are summarized in the next slides. Case number 1, 58-year-old female with bilateral glaucoma suspect. Fixation loss was high in both eyes. False positive error was high in the right eye. The glaucoma hemifield test was outside normal limits in the right eye. In pattern deviation plots, central artifact was observed in both eyes. Case number 2, 47-year-old female with bilateral primary angle closure. Fixation loss was high in both eyes. False positive error was high in the left eye. The glaucoma hemifield test was outside normal limits in both eyes. In pattern deviation plots, upper peripheral artifact in the right eye and central artifact in the left eye was observed. Case number 3, 46-year-old male with bilateral ocular hypertension. Fixation loss was high in the right eye. The glaucoma hemifield test was outside normal limits in both eyes. Although the visual field test demonstrated good reliability indices in the left eye, the glaucoma hemifield test was outside normal limits. In pattern deviation plots, upper paracentral artifact was observed in both eyes. Sorry. The pre-COVID visual field test reliability indices of these 3 cases were within normal ranges, and there were no glaucomatous defects. Case number 4, 67-year-old female with right eye primary angle closure and left eye with primary angle closure glaucoma. Although the visual field test demonstrated good reliability indices, the glaucoma hemifield test was outside normal limits in both eyes. In pattern deviation plots, there was paracentral artifact, which was not present before, in the right eye and progression suspect in the left eye. The patient's pre-COVID visual field test reliability indices were within normal ranges. There was no glaucomatous defect in the right eye. However, the left eye had nasal step with central defect. Due to patient complaints of fogging during the testing and low visual field test reliability indices, the tests were repeated after securely taping the mask to the bridge of the nose. In all tests, the reliability indices improved, showing no significant differences with pre-COVID tests. With the pandemic, few studies have evaluated artifacts in the visual field testing that may occur with the use of surgical masks. The above-mentioned study aimed to investigate if wearing a mouth nose mask impairs the visual field function in normals. The authors concluded that visual field function was observed to be significantly impaired in the inferior nasal sector while persons were wearing a mouth nose mask, especially when the nose clip was not correctly used. Unfitted masks can simulate visual field progression in around 6% of cases, mainly in the inferior hemifield, and increase significantly the rate of fixation losses. The use of a surgical mask with an adhesive tape covering the superior border may reduce mask-related artifacts, although concomitant progression cannot be ruled out in all cases. It should be kept in mind that while there may be poor indices in patients without glaucoma, the indices may be within reliable range in patients with glaucoma. These cases highlight the need to be aware of improperly fitted face masks as a cause of artifact on visual field test. The main effects of poorly fitting face masks on visual field test reliability indices were increased fixation losses and false positive errors. Low visual field test reliability indices are a warning to repeat the test. However, as in our series, although the visual field test reliability indices are within normal ranges, fogging artifacts that may mimic a new glaucomatous defect or progression can be seen in the pattern deviation plots. The use of a surgical mask with an adhesive tape covering the superior border may reduce mask-related artifacts. Thanks for your kind attention.
Thank you very much for this presentation. We'll take the questions afterwards. Now, the last presentation of today, efficiency of orthokeratology in stopping the progression of uncomplicated acquired myopia during the COVID-19 pandemic. This one is from Moldova, Rodica Bilba.
Good evening, dear colleagues. The topic of my presentation will be focused on efficiency of orthokeratology in stopping the progression of uncomplicated acquired myopia during the COVID-19 pandemic. According to the National Agency for Blindness Prevention, the incidence of myopia worldwide in 2050 will affect up to 50.2% of the world population, of which mild myopia will be 40% and moderate myopia 9.8%. Infection control measures imposed during the COVID-19 pandemic, one of the worst epidemic diseases in the history, have accelerated the adoption of digital technology worldwide. According to UNESCO, approximately 1.37 billion students in more than 130 countries globally are at risk of progression myopia due to digital life or e-learning, replacing face-to-face learning in the classrooms. As a prolonged battle against COVID-19 is predicted, there is a real concern that the COVID-19 pandemic can insidiously exacerbate the myopia epidemic. The aim of the study is assessing the efficiency of orthokeratology in the COVID-19 pandemic period. So, in the study included 120 patients who wore OK lenses over 3 years. 40 patients wore OK lenses continuously during non-pandemic period. Another 40 patients discontinued orthokeratological treatment for 3 to 6 consecutive months in the third year of non-pandemic period. And another 40 patients wore OK lenses irregularly, on average at least 3 nights per week in the third year of the surveillance, which coincided with the COVID-19 pandemic period. All groups were divided according to the degree of myopia, mild or moderate, age 6-17 years and 17-19 years, and the presence or absence of familial factor. All of patients have been examined based on standard methods. So, does myopia progress after discontinuation of orthokeratology? The data obtained in the study show that the first 2 years of surveillance in all study groups, the evolution of the annual gradient of myopia progression was similar without statistically significant difference. The difference between these two values manifested in the first year of the study. In the group with mild myopia and 7-60 years of the age, who applied OK regularly during the pandemic period, the annual gradient of myopia progression increased statistically significant up to 15%, compared with patients who apply OK continuously in the non-pandemic period, where the progression was on average of 5% of the initial value. Also, in cases of irregular wearing of ortho-K lenses during the pandemic period, the annual gradient of myopia progression increased significantly more in the group of present familial factor. In the group where patients discontinued OK treatment for a continuous period of 3-6 months, the annual gradient of myopia progression increased significantly in the third year of the study, up to 70% from initial data. In the group with moderate myopia and 16 years of age, the evolution of the annual gradient of myopia progression increased to 12.3% in group who regularly apply OK lenses in the pandemic period, compared with patients who applied uninterrupted OK in non-pandemic period in third year was on average of 2.5% in the initial value. In the group where patients discontinued OK treatment for a continuous period of 3-6 months, the annual gradient of myopia progression increased significantly in the third year of the study and averaged 45% on baseline. In both groups with irregular wearing of OK lenses, the annual gradient of myopia progression increased more significantly by patients with present family factor. In the group with mild myopia and 17-19 years, the annual gradient of myopia progression was 3.1% in the group who apply OK lenses irregularly during the pandemic period, compared with 1.8% in the group who applied OK lenses continuously in the non-pandemic period. However, the difference between the group was statistically insignificant. In group with discontinued OK treatment for 3-6 months, the annual gradient of myopia progression was up to 31.1%, which was significantly higher than in previous group. Compared to previous group, in the group with moderate myopia and 17-19 years, the dynamic of the annual gradient of myopia progression was similar during the all 3 years of surveillance of the patients who applied the lenses continuously in the non-pandemic period and irregularly in the pandemic period. In group who discontinued orthokeratological treatment for 3-6 months, the annual gradient of myopia progression was 17.1%. Analyzing the evolution of the annual gradient of myopia progression in the group of patients who wore OK lenses irregularly during the pandemic, the rate of progression of myopia in the first and second year of surveillance was reduced to 16.3% and 6.5% from the initial value, namely. In the third year of surveillance, which coincided with the pandemic period when patients applied OK lenses irregularly, this value increased up to 10.1%. Questioning the patients show a similar level of visual psychological comfort in the group which applied OK lens continuously in the non-pandemic period, 57.6 points, and irregularly in the pandemic period, 16 points. Conclusion, the results of the study showed that interrupted wearing of OK lenses during the pandemic period leads to an increase in the annual gradient of progression of myopia compared to their regular wearing in the non-pandemic period. This could be due not only to the irregular wearing of OK lenses, but also due to the prolonged time in front of the gadget and the reduced outdoor time imposed by the self-isolation regime. In the group of patients who discontinued orthokeratological treatment for a period of 6 months, was registered a significant increase of the annual gradient of myopia progression compared to patients who apply OK lens continuously. At the same time, the value of this index constitutes on average 40% of its initial value. The questioning of patients show a statistically similar satisfaction between the group of patients who perform uninterrupted orthokeratological treatment during the non-pandemic period and those who apply OK lenses irregularly during the pandemic period. Mostly, this was due to the reducing of the visual needs of patients in self-isolation, especially those related to distance vision and psychological comfort determined by sight. In the both pictures, is the same person, is my patient who wore the OK lenses since his 6 years age till 21 years age. Thank you for kind attention.
Thank you very much. Okay, now we have some time for questions and answers. Any suggestions, any comments or presentation questions? You can stop screen share, Dr. Bilba. Now, okay, while we are waiting, are there any questions for the first presentation by Professor Douali and Lia Georgikashvili? Any questions? Practical solutions in ophthalmology during the COVID-19 pandemic. Does anyone have any suggestions or pearls for preventing ourselves, especially during the examination? Well, I think most of us use masks. I personally have only one chair for me and one chair for the patient in my room where I make the examinations. So if somebody else wants to talk to me, they can talk to me from the door. I don't accept them inside. Normally, in our practice, patients come with relatives inside, except for the children, of course, but otherwise, I only take one person and there is no chair, so they cannot sit down in my room. This is my precaution also with mask and the polyethylene screen. Okay. Now, any questions or comments for the second presentation by Dr. Bulut, the effect of COVID-19 in home confinement on myopia progression in children? I think because most children stayed inside and that it was the lack of sunshine, it was a major factor. And to keep the children busy, many patients let them play with the telephones or iPads, or they watch television. I mean, I am sure that even if it is not documented so much, there is some negative effect of the COVID on the progression of myopia in children. What do you say, Asker Bey?
Exactly right, dear Kashkanoğlu. You say correct. During home confinement COVID-19, children spend more times in home and play game with table or tablets or telephone because of this spending time home. Myopic progression is increasing.
Okay, thank you. And any comments or questions to Dr. Demirtas about visual field artifacts in glaucoma with surgical face mask during the pandemic? Okay, I have again one comment. Why do we use masks during the visual field examination? I mean, okay, the nurse uses the mask and the patient is seated on the visual field instrument and she can take the mask off and they can continue by themselves.
Thanks for your question. Because during visual field tests in one day, we have to perform maybe 20 visual field tests, and the duration between the patients are very, very close. Because of this reason, we couldn't clean the visual field test inside. Because of this reason, we use face masks.
I understand, but is there evidence that inside the ball there is virus? If the patient doesn't use their mask, and wait 10 minutes between patients.
In fact, I haven't read any paper about this.
Okay. Just a thought. Okay. Now, the last presentation, efficiency of orthokeratology in stopping the progression of uncomplicated acquired myopia during the COVID-19. Very nice presentation because here in Turkey, this orthokeratology is very rare. Around me, I don't know anybody who does it. Maybe there are a few doctors. And congratulations, Dr. Bilba.
Thank you.
And your patient, how was the myopia before and after, or how much did you reduce the myopia with orthokeratology?
It depends what myopia, what degree of myopia we have, and presence or absence of familial factors, and the ages of patients. So it's different results. For example, for mild myopia and ages 17, myopia is higher. The gradient of progression is higher in comparison of other groups.
Mm-hmm. Okay. Thank you. Any other questions?
Thank you for you.
Okay. If not, Professor Bendelic, can you present the next presentation?
Well, thank you very much. Thank you very much, dear professor, and thank you very much for all speakers. And I like to do very small, very short comment. In my opinion, all presentation very interesting and very practically. It can be used in our work. And well, the reality say the problem. The pandemic situation, it's still to be present, and of course in our work it's very important to use all step for protect the doctors, to protect the medical staff, and of course to protect our patient. Thank you very much, and we practically finish today's session, and before to finish today's session, we invite, we offer time for one of our sponsors for some presentation. World Medicine.
Good afternoon, dear doctors. The company World Medicine Ophthalmics welcomes you. I will present you some products of the company. Aptecton is an eye drops. It contains Nepartenac 3 milligram per milliliter suspension. The mechanism of action, Nepartenac is a non-steroidal anti-inflammatory drug and a prodrug that is metabolized into its active form, Ampenac, following ocular administration. Delivering Ampenac as a prodrug permits increased corneal penetration and high aqueous concentration of the compound. Clinical efficacy has been demonstrated in several studies performed on Nepartenac. Faster postoperative anti-inflammatory action than other steroidal anti-inflammatory drugs. Inhibition of prostaglandin production by 90% over 5 to 10 minutes after administration, as opposed to diclofenac. Anti-inflammatory and analgesic action of Nepartenac greater than postoperative corticosteroids. The results are presented on the first day of treatment. where an improvement in symptoms is observed. And the results of treatment of Nepartenac over 30 days were observed disappearance of all symptoms of a slight maintenance of postoperative pain. Nepartenac has high postoperative analgesic action. Was observed removal of pain in patients in 96% of cases after treatment of 7 to 14 days postoperatively. Also, the efficacy of Nepartenac has been demonstrated in maintaining mydriasis during phacoemulsification surgery. The clinical efficacy of treatment with Nepartenac after laser peripheral iridotomy, we observe the patient were treated with Nepartenac from 2 weeks to 4 weeks, and does not change the intraocular pressure comparative with corticosteroids. Also, the clinical efficacy of Nepartenac has been demonstrated to reduce postoperative chystoid macular edema. The treatment was performed for a month, where the results of the treatment are very good. Nepartenac has low systemic bioavailability, low plasma concentration after administration, good distribution in the tissues of the eyeball, both on the anterior segment on the eyes and in the posterior segments, retina and choroid. Maximum concentration in aqueous humor more than 30 minutes after administration. Convenient to administer administration once a day. Well tolerated by patients and with minimal insights of side effects. And it does not change intraocular pressure compared to corticosteroids. Nepartenac can be used in case of prevention and treatment of postoperative pain and inflammation associated with cataract surgery. Reduction of risk of postoperative macular edema development in case of surgical removal of cataract in patients with diabetes. After peripheral laser iridotomy in patients with angle closure glaucoma. And dosage and administration routes only for topical administration. For prevention and treatment of postoperative pain and inflammatory events after removal of cataract, instill 1 drop of the drug into the conjunctival sac of the eye once daily. Treatment is commenced 1 day before surgical removal of cataract and is continued for the first 2 weeks of the postoperative period, including the day of the surgery. Is still an additional drop on the drug 30-120 minutes before the surgery. And for reduction of risk of postoperative macular edema development after removal of cataract in diabetes patients, is still 1 drop into the conjunctival sac of the eye once daily, starting from the first day of cataract removal, then on the day of the surgery, and for 60 days afterwards. Is still an additional drop of the drug 30-120 minutes before the surgery. Vivoxa is Moxifloxacin, 5 milligram per milliliter eye drops. Mechanism of action, moxifloxacin is a fourth generation fluoroquinolone 1, which have a dual binding mechanism of action, inhibiting both DNI-GRAS and topoisomerase 4 in gram-positive species by disrupting the processes of replication, repair, and recombination of bacterial DNA. Moxifloxacin has a wide spectrum of action, gram-positive, anaerobic, and other microorganisms. Has minimal bacterial resistance due to double mechanism of action and high concentration of the drug in diseases which exceed several times the minimum inhibitory concentration. Moxifloxacin eye drops has a maximal concentration in ocular tissues, tear film, cornea, aqueous humor, ciliary body. Guaranteed safety and low toxicity, absence of epithelial and endothelial toxicity, no aggressive preservative benzalkonium chloride, no changes in visual acuity, and absence the disorder or the integrity of the ocular surface in patient with cataract. Benefits: wide spectrum antimicrobial. In therapeutic concentration, it has bactericidal action, good bioavailability, and slow elimination from the body, high sensitivity to most microbial agents, minimum bacterial resistance to fluoroquinolone 1, maximum safety, absence of benzalkonium chloride preservative. Therapeutic indication, topical treatment of conjunctivitis and purulent bacterial blepharitis caused by moxifloxacin sensitive agents, keratitis and bacterial ulcers, prophylaxis of postoperative complications. And administration for adults and children older than 1 year, 1 drop of the drug Bivoxa instilled in the affected eye 3 times a day. Usually improved occurs within 5 days. The treatment should be continued in the next 2 to 3 days. And Slezavit is a complex with vitamins, minerals, and carotenoids. Vitamin A, vitamin B1, B2, B6, vitamin C, vitamin E, lutein, zeaxanthin, blueberry extract, chromium, zinc, selenium, copper. Vitamin A in composition of the Slezavit increase local immunity, maintains the activity of cell that synthesize the components of the tear film, ensure long-term comfort. B vitamins improve macrocirculation in the anterior part of the eye, stimulates the synthesis of the tear film, intensifies the regeneration of the cornea. Zinc regenerates the epithelial cells of the conjunctiva and cornea, stimulating the synthesis of tear film components and intensifying the regeneration of the affected cornea. Lutein and zeaxanthin have a marked antioxidant action, protecting the tissues of the eyeball from the destructive action of free radicals. Anthocyanins stimulate the production of rhodopsin, improve visual acuity and vision in case of prolonged exposure to light, improve macrocirculation and have an anti-inflammatory effect. Slezavit is recommended in case of difficulty in adjusting the eye to prolonged reading, prolonged work on the computer, prolonged TV watch, wearing contact lenses, prolonged driving, the influence of bright light, worsening of adaptation to condition of low light or dark, age change in the retina or degenerative processes. In pediatrics, Slizavit stops the vision loss process, improves the state of the mucosa, prevents or reduces the progression of myopia in children and adolescents in the processes of development, increasing the duration and intensity of visual efforts. We can use Slizavit 1 capsule per day for 1 to 3 months, from 2 years and older. If necessary, open the capsule, mix the contents in a teaspoon with a small amount of water. Thank you for your attention.
Thank you.
I have one question.
Yes, please.
Now, Affecto, Nepafenac, recommended, because there's another preparation by Alcon, it's the same, it is 3 times daily. And this one is only 1 time daily.
Because,
so it's very interesting because I don't like too many drops. What is the difference which makes it effective once a day?
Because Affecto contain 3 milligram per liter Nepafenac, which is equivalent 3 times days administration 1 milligram per milliliter Nepafenac.
So
And because this is Affecto, we administrate just 1 time per day.
Very good, because 3 times.
Because concentration is 3 milligram per milliliter.
Very good, thank you.
Thank you. Other questions? Okay, thank you. Daniela, okay, thank you.
Thank you.
Well, in case when we haven't other questions, I thank you again for all presentation. I thank you again to all speakers, to all moderators, and of course to thank you again to board of Black Sea Ophthalmological Society, local organizing committee, and we have one small spot of sponsors, and you can start it. And we for today we finish, and we will continue tomorrow, the next session tomorrow morning, 9 o'clock. You are welcome, everybody. Thank you very much.
Bye-bye.
Bye-bye.
Thank you very much.
Thank you very much.
До свидания.
До свидания.
До завтра.
Завтра. Good luck.
Очень хорошо, все приятно, спасибо.
Взаимно.
Hello?
you.